Good morning. Welcome to the Plenary Session 1, International and Regional Systems, Policies and Programs. My name is Sawakon Ratana Vichitrasin from Mahidol University in Thailand. And with me is Andreas Seiter from the World Bank. I'm so glad, it feels wonderful to be here with all of the participants today and realize that these ideas that's generated from small group discussion from our small group in Boston back in 1995 or 96 has turned out to be 3 conferences, bigger and stronger. So today we are going to the first plenary session which has 2 parts. The first part will be on the improving use of medicines, where are we today, which is a talk. And then the second part will be on the corporate responsibility of pharmaceutical companies. The talk and then comments from 3 panelists. So let me begin with session 1, improving use of medicines, where are we today, which will be given by Dr. Kathleen Holloway, Regional Advisor, Essential Drugs and Other Medicines from the World Health Organization Regional Office for Southeast Asia, CRO. Please, Kathleen, the floor is yours.
Good morning, ladies and gentlemen. It's really a very great privilege and pleasure for me today to give you a talk on improving the use of medicines. Where are we today? Firstly, a brief history. Rational use of medicines was defined in 1985 in Nairobi, and this was followed by an endorsement by a World Health Assembly resolution shortly afterwards. We then had, in 1990, the formation of INROOD, which is one of the sponsors of this, the main sponsor, I would say, of this conference. And at that time, we formed the WHO INROOD drug use indicators. We developed training courses on how to promote rational use of medicines. In 1997, we had our first ISIUM, and here we shared information on interventions to promote rational use of medicines, mainly in public primary healthcare facilities. And there were recommendations to do more on hospital drug use, community drug use, and to evaluate the impact of policies on drug use. Then in 2004, we had our second ISIUM, and at this conference we shared information on 25 areas of drug use, and there were recommendations to implement national programs, to scale up successful interventions to national level, and to do more on community use. And these recommendations were actually incorporated in 2007 in a World Health Assembly resolution. And unfortunately, we have not, due to lack of funds, been able to implement all the recommendations in that resolution. So WHO actions. Well, the WHO resolution in 2007 urges member states to consider establishing and or strengthening a full national program and or multidisciplinary national body involving civil society and professional bodies to monitor and promote the rational use of medicines. This year, in the Southeast Asian region, we had a regional committee resolution which urges member states on, the resolution is on national essential drug policy and rational use of medicines, and it urges member states to establish or strengthen a dedicated department, division or unit in the government, guided by a broad-based, long-term independent steering committee, to monitor medicines use and to coordinate strategies to promote rational use of medicines and to develop a roadmap for action based on a situation analysis. Now, since ISIUM II in 2004, WHO has continued to promote the essential drug concept, to support training on promoting rational use of medicines, to monitor drug use in primary care and policy, to support research on cost-effective interventions and undertake evidence-based advocacy, And we have been developing a situation analysis tool for use by countries to identify problems and solutions to inform national planning. Now, I'd just like to spend a few minutes talking about and showing some of the evidence from research about where we are now. Firstly, the WHO database on medicines use in primary care, 1990 to 2009. Now, much of the information that I'm going to be sharing with you now is available in more detail in different abstracts in this conference. This information is available in abstracts 337 and 338, and both of these will be presented in the breakout groups after this plenary session. The left-hand graphic shows that adherence to guidelines is still less than 50% in all regions of the world. The right-hand graphic shows quite clearly that the treatment of acute childhood diarrhea is much better in the public sector than the private for-profit sector. More ORS use, less antibiotic and antidiarrheal use. From this same information, we have information on the impact of interventions. And here you can see a list of interventions on the left-hand column. And in the third column, you see the median impact. The yellow shows the least effective intervention, printed materials, approximately 8% improvement in drug use. But multi-component interventions, such as is highlighted at the bottom in the green bar, provider and consumer education with supervision, you can get up to 40% improvement in a targeted outcome. Now, WHO has also been monitoring drug policy, and we send out a questionnaire to ministries of health every 4 years. The last surveys were 2003 and 2007, and there's a survey going on this year in 2011. On the left-hand side, you see the sort of a selection of drug policies that WHO would recommend all countries implement to promote the rational use of medicines, such as regular drug use audit, a national strategy to contain antimicrobial resistance, not having antibiotics available over the counter, public education, drug and therapeutic committees, a national drug information centre, obligatory continuing medical education, training medical students on the essential drug concept, and updated guidelines and essential medicines lists. And you can see that a lot of this information can be downloaded from the web. You can see from that publication in the top right-hand corner. Now, 60% or less of countries are implementing these policies. Quite often, only a quarter of countries are implementing some policies. And this is not costing, it doesn't cost millions of dollars to implement these policies, so why is it that countries are not implementing these policies? And it's actually worse than this, because this is what ministries of health say they are doing. And often the things they say they are doing, the implementation is not so good always. So perhaps it's because there's no good evidence that these policies work. So WHO has used their data to investigate the question, do countries with drug policies have better use than those without? Now, you can find more information on this in abstract 339, but basically we merged the data from the drug use database that we have and the policy databases that we have. So from the period 2002 to 2008, we looked at the difference in 12 medicines use indicators between countries with policy and without policy, expressing it as percentage better or worse use. And then we took the median of percentage or better use across these 12 indicators, calculated for countries with policy as compared to countries without policy. We also undertook a linear regression of the number of policies identified to impact on drug use versus the drug use. And here's just a slide showing that some policies, such as drug and therapeutic committees, training undergraduates on the essential medicines concept, a dedicated unit in the Ministry of Health, Drug Information Centre, public education, are associated with better use, and some policies, such as untrained prescribers and using sales revenue to supplement prescriber salary, are associated with worse use. Here it shows the correlation of antibiotic use for viral upper respiratory tract infection versus the number of policies. So on the x-axis you have the number of policies, and on the y-axis you have the percentage of upper respiratory tract infection cases treated with antibiotics. In the bottom right-hand corner, you see Oman. Greatest policy implementation, least amount of antibiotic use for viral upper respiratory tract infection. What other progress has been made? Well, there's been a lot of other progress made. In Europe, we have surveillance systems for resistance and use, EARS and ISAC, and having this information has stimulated a lot of activity at national level in Europe to contain antimicrobial resistance. We have the Strama program in Sweden, we have other initiatives in France and Belgium and the UK, and we've had public education programs throughout Europe, and there's been a review of this by Huttner et al. Recently. We've had quantitative reviews of intervention effectiveness on IMCI, there's an abstract in this conference, and also on health worker performance, another abstract in this conference. We have been developing a national situation analysis tool, as previously mentioned, to inform national planning, and we have 2 abstracts on this. We've had development of monitoring tools and indicators and interventions to improve adherence to ARVs, and we have a whole host of abstracts from sub-Saharan Africa on this. We have abstracts on costing the irrational use of medicines, and we've undertaken community-based surveillance of antimicrobial use and resistance. So this is a summary of some of the research, rather dry information about really the dire state of affairs with regard to rational use of medicines, but a lot of progress has been made on what interventions work. But we've also, in the Southeast Asian region, been undertaking some situation analyses in the last couple of years of looking on the ground what is going on. So I'd like to share some of this information with you that I found. First of all, few countries know what drugs they're using. There's very little monitoring and virtually no prescription audit. Drug supply systems are mostly manual and inefficient, with poor quantification and stock management. Most countries have multiple brands of the same drug. In India and Bangladesh, we have more than 500 products for some molecules, particularly antibiotics and analgesics. Here are what some people say. We cannot limit the number of products for a particular molecule registered because of complaints of the Monopolies Commission. Having so many brands makes it difficult to regulate the market and convince doctors and patients to follow any EML. We had to choose the lowest price tender because of new government financial rules, even though we knew it may result in non-delivery due to supplier default. Essential drug lists. Unfortunately, they are generally not used by public hospitals, the private sector, or insurance companies. They are only partially used, at best, in public primary healthcare facilities. In all the countries visited, we held a national workshop with multidisciplinary in nature with multiple stakeholders to discuss the problems in a cross-sector cutting way and to identify problems, prioritize them, and find solutions to use in national planning. And this was very greatly appreciated in all countries. There's hardly ever been workshops like this before to discuss these kind of things. Now a few photographs. Indonesian puya, or powder, pulverizing 2 or more, often 5 to 10 drugs into a powder, and then allocating doses by eye. I observed this in every kind of facility, from tertiary referral hospital down to the lowest healthcare facility. Indian private practice, sitting in a private waiting room. Every 4th patient was not a patient. He was a drug company representative. And we can see here the dispensary, and in the background you can see the advertisements from the drug companies, and on the right-hand side you see some of those advertisements in more details, plain to see in front of the patients and the doctors. Nepal health worker views. An auxiliary health worker, 1-year trained paramedic. For children under 5 years with pneumonia, I must give amoxi syrup according to IMCI guidelines. Since we are short of amoxi syrup, and have short-dated chloramphenicol syrup, I'm prescribing it to children of more than 5 years with pneumonia in order to use up the stock. And here we see in that bottom photograph empty shelves of needed medicines and dumping on the floor of unneeded medicines. A pune, that is a totally untrained person working in the lowest type of health facility who sort of fetches and carries. When Dr. Saab is a paramedic, when Dr. Saab is not here, I do dressings and give out cetamol. For young children, I give out Cotrim. The top right-hand photograph is of a funeral pyre in northeast Nepal. I put it here to remind us that many populations live and die without access to healthcare. But if they do have access to healthcare, first, let us do no harm. How can we ensure that drug use does not contribute to untimely deaths? So the challenges, what are they? Well, I would say that there's lack of institutionalization to promote rational use of medicines. Often there is no unit in ministries of health to monitor medicines use or coordinate strategies to improve use. There's lack of investment and policy implementation. There's fragmentation of health systems, largely driven by donors. There's an imbalance of drug information. Most prescribers get their information from drug company representatives. There's a lack of pharmaceutical public health experts. Medicines issues are not taught in most public health degrees. Public health has itself fragmented into subspecialties with very limited pharmaceutical public health expertise, and I would say in many countries, general public health expertise available, and research needs. Well, how do we develop a national integrated health system approach to promote rational use of medicines, and how do we monitor policy implementation? We have these recommendations and resolutions, but how do we do it? I don't know. What is the impact of non-health, for example, fiscal policies, on health and medicines use? So the challenges, the reality, well, in my opinion, continued irrational use of medicines and lack of action to tackle it is the biggest public health scandal of the 21st century, and frankly, I would say it's one of the biggest public health scandals of the 20th century. Irrational use is bad news, and nobody likes to hear about it. Many countries are unwilling or unable, and also donors are unwilling and do not fund projects to promote the rational use of medicines. WHO programs, well now most international training and research has stopped due to lack of funds. Unless funds come, WHO's databases to monitor drug use, intervention impact, and pharmaceutical policy will be abandoned, and there will be no more data or evidence for advocacy. Searching for funds for WHO post the 2007 resolution has been frankly a nightmare. Many proposals and letters of intent were developed. None were accepted. Donors were not even happy to have rational use component as part of an umbrella grant. Here is what some people said to me. We only deal with getting drugs to the country. Who should deal with how the drugs are used? This project would take too long, and we need results in 3 years. So what's the way forward? Well, I would say we need to develop contextualized national coordinated plans of action based on a situation analysis, be context-specific. And we're developing a tool for this, but we lack funding to take it forward in a very speedy way. We need a lot more training and research in the pharmaceutical sector. Schools of public health should teach about the pharmaceutical sector, clinical pharmacology and pharmacy courses. There should be much more of them, and they should teach the skills of drug use monitoring, formulary management, how to manage drug and therapeutic committees. And journals should publish much, much more on policy and use issues. We need to continue to monitor the situation and progress made. We need to continue to monitor drug use intervention impact and pharmacy policy impact in order to provide evidence for advocacy. And if we don't continue with advocacy, nothing will be happening. And I would say we need to spend 5% of all medicines budgets on promoting rational use of medicines. All donors should proactively contribute to this. But lastly, I would say, and perhaps most importantly, we should move from research to activism for change and replace competition with collaboration and cooperation. And I have seen so much competition. Competition in WHO departments, competition in university departments, competition between NGOs, competitions between donors, competitions in ministries of health to be in the department that receives global fund money, competition even for resolutions at the World Health Assembly. And I think we could have made a lot more progress instead of this competition, replacing it and working together, having collaboration and cooperation. So lastly, we need to continue the debate. We know an awful lot of what we should be doing, but we are not doing it. So we need continued political pressure and debate. The WHA 60.16 resolution requires two-yearly reporting to the Assembly. So let's use the opportunity and bring this issue up every 2 years. We need to lobby for national, regional, international, multi-stakeholder collaboration in development of the pharmaceutical sector. For example, all donors supplying medicines should agree to allocate some of their funds to monitoring the use of medicines and promoting rational use of medicines for all medicines, not just the medicines of their program. Pharmaceutical companies should agree to limit and publicly declare their promotional activities and stop all inappropriate advertising. Parent companies should monitor daughter companies. And lastly, I would like to thank for the adoption of the WHA 60.16 member states, INRUD, WHO colleagues, and networks and NGOs, particularly the Essential Drug Project UK, the Economical Pharmaceutical Network, Health Action International, and REACT, Action on Antibiotic Resistance. Thank you very much.
Kathy, thank you very much for a rich and moving presentation that I think perfectly sets the stage for the days to come here. I have one question that came to my mind when I listened to you. If we think of these more than 50% of countries that haven't done anything in terms of rational use policies yet, what would be the one thing that you would recommend them to do first in terms of a cost-effective intervention to get get started in this difficult field?
Thank you for that question. I think that's a very, very relevant question. That's one of the reasons we're trying to develop this situation analysis tool to bring people from different disciplines together to get them to prioritize what is the major problems and identify the major solutions, because I think this will vary from country to country. We know the basic policies that countries should be implementing, but if we want to answer the question, which one first, then I think we have to go to the country and talk with the people there, and that's why we are trying to develop this situation analysis tool and a method to do this, and not only for us to do this, but eventually to transform it so that countries can do it for themselves.
Thank you. So as I thought, no simple answer. So our next speaker is certainly one of the leading thinkers in the field of corporate social responsibility, good corporate citizenship. Professor Klaus Leisinger is the president of the Novartis Foundation for Sustainable Development. He has published many books, many articles in this area. Klaus, thank you for coming to Antalya. The stage is yours.
Okay. I said good morning, and I said I have only 10 minutes to explain something to you for which I could easily use a whole semester. The social and the political context of what we are discussing here is, for me and Kathleen, the biggest human tragedy, because we have the resources, we have the skills, we have the knowledge, and most of these things would not be necessary if we would do together the right things. We also know that this is such a multi-dimensional affair that any single part of the solution has its limits. So if we really want to have a sustainable improvement of health, it is we have to fight at many fronts. And I'm not saying that to avoid a thorough discussion on what should the industry do, but the point that I want to make by showing this context is that industry alone should not be an actor, it should be a coalition of those who want to make a difference. Health is highest in all countries on the top personal concerns. If one asks everywhere in the world, people voice this. Of course, it is different in HIV-stricken countries than it is in other. There are specificities, but the point is, and that is very clear, that drugs do play an important role along with well-trained and motivated staff of medicines. So yes, even if everything were right and the drugs weren't there or the drugs would be out of purchasing power, it wouldn't help a lot. A lack of access to essential medicines and vaccines are said to result in about 10 million deaths. And many NGOs and civil society media see in this context patents and prices to be the most important obstacle. And I will dare to say that this is only partly true. Also from the United Nations, most of the Millennium Development Goals are health-related. And that's another scandal that many people are aware of, that particularly Millennium Development Goal 4 and 5 having to do with infant and maternal mortality is tracking behind in most of the countries. And even, there would be the most low-hanging fruits and not particularly drug-related. So what is a company that is competing with integrity responsible for? There is this must, this ought to, and this can dimension, and Richard Lane continues to remind me there should be a must and not a must not dimension as well, and it has to do with inappropriate marketing as well. I'm fully aware of that. But my suggestion here is a lot of the things that we are discussing under the worst cases are not good management. It's not an ethical debate, never more or less, or primarily. It has to do what is good sustainable management, and a lot of the bad cases are just not good management. But then there is a corporate responsibility dimension beyond that, and a lot of what we discuss with regard to access to medicine probably goes into that. And if you look at the Global Compact, which is at the moment the most prominent corporate responsibility raster, there are no things like access to medicine or anything that we discuss here in there, and yet it should be, because if you ask people all over the world in what terms are you measuring the responsibility of a pharmaceutical company, it has to do, amongst others, with access. Now, the problem here is who is responsible for what if you have failing states and if you have failing markets. And let me say here, the question is not at all, should one do something? The question is, what ought to be done, by whom, in cooperation with whom, where does the buck stop? Where do we have to be aware that somebody else's responsibility should not be pushed over into the private sector? Where do we have to remind the private sector that what is currently done is not appropriate in a more in a holistic way of looking at it? And these questions today are answered by the individual companies, which in a way is a pity because, at least in my experience, the worst example of the pharmaceutical sector is predominantly having an impact on the image of all the companies, regardless of what they are doing. And in many cases, you see companies that are doing a real lot and yet do not get the reputation capital that they ought to get. My experience in the project, my foundation has a number of projects that we are doing in the field, and this is one of them that we did in East Africa on access to malaria. And a lot of the issues there are beyond the pharmaceutical industry's reach. It has to do, but I'm aware that you know that it has to do with strengthening health systems, or again, taking Richard's, it has to do that companies should not do anything that undermines health system strength. But one project that we are doing, the leprosy project, where we are giving away all the drugs for free, this still does not necessarily mean that the drugs arrive where they ought to arrive and are taken the way they ought to be taken. So, you know, we need solution teams that kind of are reflecting this complexity. So what's the basket? What's the toolbox? It is differential pricing, but it's not differential pricing alone, because differential pricing as such is not disputed. It is the question for what products, it is the question in what countries, it is the question for what patient groups. Licensing for market failure, philanthropy, pro bono research, all these things are done. If you go to the DFID study, they are done by a lot of companies, by far not by all companies, but you know, the fact that they are done is an important fact. Yes, I know that you have to put things into perspective. One of the issues managers and corporations are afraid of is that if they give differential pricing in one country, let's say for a sub-Saharan African country, that a country like Norwegian are using this as an external reference price, and then it's not going to be done, because what managers are afraid of is that any action with regard to preferential pricing is eating into what they consider their normal markets. Market segmentation, should it be done country-wise? Some companies want to suggest that. Should it be within the countries, between public and private market? Should it be special patient assistance programs? Here, I would just say one sentence: we need much more innovative thinking here, and much more creativity, and much more cooperation with thinkers outside the industry to make progress in this regard. The point is that if you look at what is currently available in most of the countries, even if all these things would be done by all pharmaceutical companies, we would still need more resources and innovative finance system. The controversy, of course, goes on for companies that are doing differential pricing or donations or pro bono research. It also goes on for the patent use. My theory has always been, it's not the question patents yes or no, it's the question, what is the responsible use of a patent? And philosophically, we all agree that nobody should die because somebody else has a patent, but then the devil is in the detail as usual. For what products? The biggest challenge here will be the non-communicable diseases. I think most of the big companies today are in agreement that for essential drugs or for tropical diseases, special programs are needed. But if we see the paradigm shift in the disease pattern, it is a question of time that the pressure to make differential pricing for the latest products, for cancer, for diabetes, or for whatever is, to do something there as well. And here I do not see a lot of movement. Donations as well. I hear something sometimes that donations ought not to be done. I respectfully disagree, particularly if a company has a lot of expertise in a given field, be it Novartis for leprosy or be it MSD for river blindness. Such programs can help a lot. Last slide, or second to last slide, is That's our malaria project, to show the complexity here. It took us many years to build up this net of connections. It took us many years to get everybody on the same page, and it still is not something that runs smoothly. So the more complex the issue is, the more complex the solution team has to be, but it also has to be robust in the sense that you build up constructive relations, that you trust each other, that you give somebody the benefit of doubt that he or she, regardless from which side they are coming, are also working in good faith. But the good story is here that this has been a successful venture, and that this might be used as a model for others. As I said, the pharmaceutical industry today is more and more aware of the fact that they ought to contribute different things than they have been contributing in the past. I see that. But different actors, they are people, let me put it like this, NGOs know things that the industry doesn't know. Governments know things that the NGOs don't know. Industry knows things that neither the government nor the NGOs do, but if they all bring what they know to the same table, we would be making better progress. I do think that if we get a small group of responsible actors together, this morning Andreas Seidler said, we need a kind of a think tank that is not part of one camp, but that has members of different camps. We had a similar discussion yesterday with Richard, that it's time that we get some enlightened people together and prove some concepts for some diseases or for some countries. Last sentence, there are a number of constructive partnerships that are successful. And as you said, Kathleen, we have made some of our best experiences with WHO departments, and we have made some of our worst experiences with WHO departments. But overall, I'm optimistic. What if I would have a wish open, it would be that we use less stereotype prejudice against people working in different silos and concentrate more on the objectives we want to reach together. Thank you.
Thank you very much, Klaus. Thank you for sharing with us real rich content in such a short period of time. And now we will have views from the three panelists coming from international organization, government, and NGO. May I first invite Dr. Richard Lang from the World Health Organization to give the response, please. You have 5 minutes.
Thank you very much. I'm very pleased to have this opportunity to comment on the presentation, but I really would like to make the emphasis that I will be commenting on this paper, the background paper that was circulated to us and will be made available on the web. And I would emphasize and encourage everybody to read the 2009 Journal of Business Ethics paper that for me was a personal bombshell. It really showed the new way of thinking that was coming from the industry, and I've really found it that this is a long, complicated paper that brings together philosophy, economics, ethics, and pragmatic idealism in a way that has not been addressed, not been published before. And I think we talked yesterday about a new paradigm. I think this is part of that. I'm pleased that there was a mention of the MDG 8. We often hear about health-related MDGs, 4, 5, and 6. And yet MDG 8 is in cooperation with the pharmaceutical industry, ensure access to affordable essential medicines. That is a very important global tool for us to use to say part of global development is access to essential medicines. I am very pleased that there was a discussion in the paper, but not in the presentation, about taxes and duties. But the neglect of the effect of markups in countries is a major obstacle. And there is almost a conspiracy of silence for governments to say the biggest problem in prices is the distribution chain. Inefficiency is part of it, but exploitation is another part. And the taxes and duties, we should be clear that this is government exploitation of the sick every time they put a tax on medicines or duties. Now, the discussion of pharma company functions, the must, could, should, do is useful, but as Klaus has mentioned, I've been hammering away at first do no harm or must not. And in both the papers, the 2009 paper and the paper that we've reviewed, there's nothing about the marketing activities of the pharmaceutical companies. And I often think when I go and talk with the pharmaceutical companies that the marketing department is in another silo far, far away from corporate headquarters. Because what we see is the corporate headquarters really talk about access to medicines as a meaningful corporate commitment. But in practice, what we see, the people from the companies that we interact with in the real world are the marketing departments. And sometimes the access to medicines message hasn't got to the marketing departments. I'm really very impressed with GlaxoSmithKline, which has broken with this model, and their least developed country division is now being evaluated not on revenue generated, but on market share. So the more medicines they are able to distribute of their company, the better the evaluation. And price and revenue are not part of the equation in their evaluation. That's the sort of interesting idea. The most exciting part of this paper and the presentation has been this idea of differential pricing plus. In addition to differential pricing, what else is necessary? And we should be absolutely clear that differential pricing always has existed, always will exist. There's no point for a company to produce a product that people cannot buy. And setting a price at a level that people can buy is the essence of differential pricing. But when we talk about the questions about which products, it's very clear to me it's at least essential and neglected. The other products, we can talk about whether that's necessary, but I think you can make a strong case that it is. For countries or particular patients or particular diseases, it has to be both. It can't be just the poor patients. So the final sort of areas of points is the business case. What is the business case for access to medicine strategy within a corporate strategy? I think we should recognize that when GSK was identified as the best company in the Access to Medicines Index, the CEO, Tim Whitty, had 20 minutes on the financial channel of CNBC called Squawk Box. How often does a CEO get 20 minutes on major global television to defend an access to medicine strategy? The second key point is that talented researchers and executives want to work for a good company. They want to work for a company that they can be proud of. And those companies that get behind this really are the ones that can go forward. So I really welcome these papers, these initiatives. It's not all the companies, it's some. But to get forward in a collaborative way, in the way that Kathy talked about, is really an important thing for the future. And I look forward to hopefully being part of that dialogue. Thank you very much.
Thank you very much, Richard, for a very great comment. May I invite now Anban to give your view, please?
Thank you very much for the opportunity to respond to the presentation. I think it's important, before I get into the detail about the response, to recognize that there's a mutual need between society and the pharmaceutical industry to have access to the medicines that the industry produces. So there's a mutual need from both sides. I think the obvious point that patents are provided so that there can be protection around the costs of R&D, and that protection is given for a period of time. But I think there's also responsibility on the side of the industry to use the period of patency in a responsible manner. And here I'm talking about transparency around what are the true costs of R&D. If you're given an opportunity to recoup these costs, it would only be reasonable that we have an understanding of what these costs are so that society can understand how much they need to pay for these products going forward in terms of that patency period. I think it's fair to say that prices are not the only factor that promotes access. There are a variety of other factors. But I think it's one of the most important factors, and that's why civil society and many organizations look at price as one of the key components. The pharmaceutical industry is responsible for the production of many valuable drugs. Many of them have reduced mortality and morbidity. But it's also important to recognize that they've produced a number of products that are Me Too's, effectively attempting to provide the same benefits as others at much higher prices. So I think it's important to recognize both of those groups of products. On the issue of market failure, I think market failure is not just about the informational asymmetry between the buyer and the seller, but it's also about the ability to purchase these products. And I think Richard makes the point that producing a product at a price that those with the greatest need cannot afford to buy it, then what is the point of producing such a product? I would have thought that in attempting to produce these products, one needs to have an understanding of who is actually going to be purchasing these products and how will they be able to afford to buy these products. I would actually ask that issues around R&D and marketing become part of a transparent process so that everyone understands exactly what happens. My engagement, for example, with the pharmaceutical industry suggests that the marketing budgets far exceed anything that the research and development budgets have. For example, the colleagues who sit in research and development tell me that their budgets are wafer thin. On the other side, the guys on the marketing side are able to spend as they please. And so the question has to be asked as to whether the costs that are related to the product are the costs of R&D or are the costs of marketing. And I think that transparency will help us resolve that debate. I think the other challenge is around the way the pharmaceutical industry is financed. I mean, the pharmaceutical industry is responsible for generating returns on investment, largely because of the pressures they have from investors. And the question must be asked as to whether that's the best way of financing the pharmaceutical industry, because investors at the end of the day would be looking for the best return on investment. That would mean that prices would have to go up, which would mean that the volume of sales has to increase. People who need the drugs have to have access to it. Many of them cannot afford these products. Is there not an alternative mechanism for financing research and development for the pharmaceutical industry so that the pressures that investors place on the industry in order for them to remain viable are removed so that we can have a more responsible approach as to how these products come to market? I think on the issue of differential pricing, I wanted to say that differential pricing shouldn't be seen as a donation as such to developing countries. I would see differential pricing as a strategy that the industry should be using in order to increase access and develop a sustainable financial model. Decreasing the price but increasing the volume for all of the countries and communities that are in Africa and Southeast Asia, for example, surely would be a far more attractive approach than trying to concentrate one's efforts largely within the developed markets. On the issue about the fear that if products are sold at lower prices in developing countries, that developed countries would demand these prices. From the South African perspective, I can say that I've not heard of a single developed country that has said to the pharmaceutical industry, we want the price that South Africa gets because we would like that price as well. I think that developed countries are far more responsible in their approach about demanding prices. And I think that's not an argument that should be put forward. I'll stop there. Thank you.
Thank you very much, Anban Pillay from the National Department of Health in South Africa. May I move next to Eva Mbago for former Equinorial Pharmaceutical Network in Tanzania for your comment, please.
Good morning, everybody. When I was asked to be on this panel, I hesitated. I thought I'm an old dinosaur. That should be some people who are much more qualified to sit in front here. They massaged my ego a bit, and so here I am. And I hope I'm speaking from a consumer's perspective, but hopefully that is also the NGO perspective. I'd like first to appreciate the work that the pharmaceutical is doing in addressing access to medicine. I think it's an excellent beginning, but I call it a beginning. And I like to look at corporate responsibility. It's not just about doing, it's about being. And I say it's a beginning because some of these are short-term. For example, if you look at the proposed toolbox, you see philanthropy, donation, pro bono, making these, those in need dependent or at the mercy of industry. Charity is short-term. Secondly, the other short-term issue is the response that most of the essential medicines are now off patent, and therefore issues of patent are not important. It is like saying, you poor people must not get any other disease except those on which the medicines are off patent. Clearly, that's not what is being said. But if today a therapeutically valuable antibiotic, and this is an issue we're discussing this week, is discovered, it will be out of reach. So I think we all agree that the nation state, supported by the international community, bears the primary responsibility for ensuring that the right to health is respected, protected, and fulfilled. This is long-term, and this is where I'd like to focus my discussion today. What's the reality? The US and European Union, you can read, large pharmaceutical industry lobbyists routinely used bilateral and regional trade agreements to limit or circumvent developing countries' ability to implement the Doha Declaration and safeguard public health. These interests affect public health protection and threaten access to medicine, but also work to counter the efforts of the Global Health Program. An example, the Trans-Pacific Partnership Agreement, which is something ongoing now, and it involves these countries, Australia, Brunei, Chile, Malaysia, New Zealand, Peru, Singapore, the United States, and Vietnam. These are not small countries, but the partnerships seem to be leading to a TRIPS plus kind of an agreement. Now, if this can happen to these big countries like this, what do you think is happening to the smaller countries like mine? And why is this happening? I think this happens because there is imbalance of power between the state and the corporate world. The pharmaceutical industry is big. It's big. To the extent that even large states, the power of industry is such that the states are now doing the bidding of industry. In other words, the tail is wagging the dog. Dr. Leisinger has described the essence of must, the could, and the should, and shown us the triangle. But this triangle is going to be made smaller and smaller and smaller. The triangle, the bottom part of the triangle, which reads must, is getting smaller and smaller when the state has no right to institute appropriate laws and regulations to increase access. So that's my first beef. The second thing is good governance system. And this is very complex, I agree, but changes at this level would be long-term. But I think the pharmaceutical industry is also part of the problem, and I'd like to see it also being part of the solution. I'll give an example. I read recently, drug companies paid $25 million to doctors in Illinois. That's only one state in the US. The drug company official says they are funding talks that provide much needed medical education led by physicians who are experts in the field. We say financial relationships between doctors and drug companies threaten patient care and influence physicians to prescribe certain medications whether or not they are the best choice. Now, why am I saying this? This is happening in the US, a big country able to, the regulatory system is strong, industry following up of their cause is strong, yet it's happening there. What do you think is happening to the smaller, poorer countries? Much, much more. So addressing good governance is a long-term solution, and I would still like to see that happening. In my last minute, I just want to talk about fair trade. We know and talk about fair trade practices. We look at it, when you think about it, you look at it from agricultural subsidies. But what about pharmaceutical industry? In the 1960s and 90s, the pharmaceutical industry was making profit. That's why it grew. At that time, patents were process, not product. and it was okay. It was fair trade. Now that developed countries cornered the pharmaceutical market, patent laws have been changed so that the rest of the world cannot benefit from reverse engineering. Now we slip back to charity with things like voluntary licensing. Don't we see this as an unfair trade? So I would like to say that, yes, things are happening, but the core, the being of the pharmaceutical industry has not changed. Thank you.
Yeah, I want to thank our three commenters. One thing, although, occurs to me when I listen to the three of you. Each of you is basically talking to the multinational research-based pharmaceutical companies. Isn't there somebody missing here? And I mean, where's the generic drug industry, the multinational as well as the national small-scale companies? Who are these reps who are visiting the doctor in India in that photo that Kathy showed us? I doubt that you will find many reps from Pfizer and Glaxo and AstraZeneca and Novartis in this practice. No? So my question would be, and we still have like 5 or 10 minutes here to continue the discussion, and maybe I want to ask this question to Kathy, because she is the one who has all, looked at the evidence of rational use, which certainly is affected also by the industry. What is our demand if we would have a representative of the generic drug companies here? What is their contribution to good corporate citizenship?
You've asked me rather a difficult question. Undoubtedly, I think the generic industry should be represented here. And also, I think that it would have been nice to have had the views of the generic industry from somewhere like India, where there's hundreds and hundreds of companies. And I think you're quite right that many of those drug representatives were from the generic industry. And there's a big role for governance in that area too. Thank you.
Richard wants to.
Yes,
comment.
can I comment and to fully agree with you and point out abstract number 924, Kirti Nasi from South Africa is presenting what I think is a very innovative approach in that South Africa is now instituting a universal code, a code that covers pharmaceutical, big pharma companies, big national companies, local generic companies, over-the-counter producers, and said there must be one marketing code. Because what we see, and we have another abstract from Vietnam, Tuan, who is talking about why do generics in Vietnam cost more than originator products. And the reason his research found was that the originator companies will not pay bribes to the doctors in the hospitals, while the Vietnamese generic companies do so. And so we need a uniform marketing code of practice that will stop these incentive payments by local generic companies and have a general approach in this way.
Thanks for the question. Given that I had 5 minutes, I didn't want to get into the generic industry, but I think you're absolutely right. The generic industry will behave in exactly the same way as any industry if there isn't a regulatory system in place. I can give you the example of South Africa. We have the largest HIV and AIDS burden in the world, and 3 years ago we were paying the highest price, one of the highest prices for antiretrovirals, and that was not the multinational pharmaceutical industry. That was our local ARV manufacturers who, if our procurement systems are weak and we're not smart in buying, the generic manufacturers will take advantage of that, irrespective of the disease or the need.
I don't know if you also expect me to say, because I think when I talked about good governance, it does imply both the research industry and the generic companies. Cuts across.
Thank you. I have a question that I would like to have the views of those of you here. Since in our meeting here at ICM, we gather hundreds of people who care about improving use of medicine and love to work together to improve the use of medicines. So I would like to hear from each of you that if there is one thing that you would like to propose so that all of us can collaborate globally to improve the use of medicine, what do you think that one thing is? And eventually, I hope that that will be a recommendation for ICM3.
Thank you for that question. I think that's a very difficult question to answer, but I would say that we should aim to have a unit in every country in the Ministry of Health, governed by a multidisciplinary steering committee, to look at the issues of irrational use of medicines in their countries, to do a situation analysis, to prioritize what things need to be done, because there are so many things that need to be done. I mean, just in the last talk, we heard about inappropriate promotion. In most countries, and certainly in Asia, there is no proper monitoring of drug promotional activities. The drug regulatory agencies need to be strengthened. But that's only one part of the story. There are many other things needed to be done. So unless you have some oversight, some forum, some coordinating body in the country with an executive and the Ministry of Health to carry out their recommendations, we can't go forward on what is the most important thing to do in this country to monitor, to follow up, to coordinate between different activities. And that was a recommendation in the last resolution. Hope it's going to be a recommendation in the next one. Thank you.
Thank you, Kathy. Yes, Klaus.
Well, if I would have to choose one, I would choose the idea of this think tank where you have relevant thinkers from different silos, so to say, but credibility with a credibility that goes beyond the specific silos. What I have seen very often, there are numerous dialogues where companies either delegate lawyers or communicators or public affairs people who have a relatively strict agenda to defend. So one talks and one agrees on words that are up to different interpretations. And here it would make sense to kind of look for an independent think tank, not only to bring together what empirical evidence is available. Obviously, there is much more than at the moment is used. Not only the policies, but also good examples on how one can find solutions that create win-win situations rather than are to the detriment of zero-sum game.
Yeah, again, a difficult question. I completely agree with both of the two previous suggestions. But in my work in WHO, I get access to enormous amounts of information that is not disseminated effectively, that we look within our medical model, we look within the business model or the trade model. And yet the integration of this knowledge, I really believe we need a global knowledge portal, information that can be brought together in an accessible way so that the pharma companies, the activists, the public sector, the ministries of health, the ministries of trade can find information that is useful for them to make these policy changes to ensure access for those people at the bottom of the pyramid. That, I think, is something which is now doable in our world of information technology. We should empower people to know what can be done.
I support many of the proposals that I made already. Maybe one additional proposal, maybe to look at the financing of marketing and redirect some of those funds, particularly the inappropriate marketing that happens, and redirect that towards the improvement of the use of medicines, to work with ministries of health, particularly those, as Kathy pointed out, that have not made inroads in terms of rational use, and say, well, we'd actually like to promote rational use. It's in our interest as well to do so, and to fund that type of education as well.
I think because the pharmaceutical industry is such a big player in the world today economically, I think the increasing of transparency to its dealing without breaking its internal secrecy would really be a good idea. So I would think that maybe a need for a global policy that kind of demands a public scrutiny and debate with all stakeholders involved to discuss any discussions that are leading to agreements or things like that that are going to impact on access to medicine. Just having that where all players are seen as equal and having that agreement. I don't know whether that's the think tank, but I think we need a global agreement on this kind of discussions. Thank you.
Okay, now it's my challenging task as co-chair to wrap up the session and then let you go to the smaller group sessions this morning. If I think back in the last hour, what was most interesting to me from the initial talk, Kathy's assessment of the situation in terms of rational use, is that this is a topic we all agree, it's all on all our lips, we constantly talk about it, now we have a big conference about it, but it seems to be also something that as donors we consider bad news and we don't want to touch. So how does this fit together? I think this is a major gap we have to think about in terms of how do we present it, how do we make it operational, how do we create cases to say we can do something about it, because everybody you will talk to in private will say, yes, of course it's wasted money if we put all these funds into buying drugs and later on they are not properly used and maybe they end even up as trash that then costs additional money to burn and get rid of. So I think this is a challenge, I think, for us to work on in the coming days and see how can we talk to the political level, in particular in the donor countries, to the people who are more impatient, who want to see things happen within 3 years. I think we need answers for that. We can't pull back and just be unhappy about it and feel unfairly treated. So the second part of the discussion about role of industry and so on. I mean, one thing which is notable, there is a handful of companies that's willing to stick their neck out, even if they still get some unpleasant things thrown at them. But I see a sufficient overlap in interests, in particular if it comes to access to expensive medicines, to the new essential drugs that are being developed for cancer, for diseases that affect the rich and the poor. I had many discussions with representatives from industry associations as well as individual companies. There are potential ways of going about this think tank idea that we discussed over breakfast, should explore that in more depth. The problem here is that you cannot have the industry sitting in a room together because out of antitrust issues they cannot talk about these things. That is a discussion that involves talking about prices. So you need a neutral platform. There is nobody yet who funds such a neutral platform, but I think this is something we can push in order to continue that dialogue. The third point I want to make, coming back, it was confirmed, we need the generic drug companies at the table in this discussion as well. A lot of the issues that have to do with in-country pricing, marketing, which is kind of the counterforce against rational use. Of course, if I am a drug company representative, I want more and more of my drugs being sold, and I want them sold at higher prices rather than the lower prices. So we need to engage at that front as well, and I think this is, maybe for the next issue or for the time in between, we have to think about how we can engage this group of companies. Overall, it's not hopeless, but I think we see some areas where we have been lacking good ideas. So, I would encourage you to keep thinking, keep talking, be optimistic, come up with pragmatic solutions. And the last word I want to say, there's a lot of posters out there, in particular about evidence on rational use, first data on reality of the use, and also a lot of posters that show how certain interventions can have positive impact. So it's not that there is no data, but I think we need to go walk around and take a look at these posters and then come back and discuss and come to conclusions as to how we can move forward on this. Thank you very much for being here, and I wish you an interesting, exciting week. See you later at the next meetings. And thanks very much to our speakers here.